We want to live in a San Francisco where hepatitis C is no longer a public health threat and when Hep C-related inequities have been eliminated. And I think part of the work that we're trying to do is not just sort of like the traditional public health, make sure, we're identifying new infections and treating them, but also kind of changing the culture of how people talk about hepatitis C.
End Hep CSF really came out of two things. One, the recognition that we had a lot of people in San Francisco living with hepatitis C, and many of them were in really vulnerable populations, HIV infected, injection drug users, people who are homeless. But the big event was in 2014. We had the tools now finally to get rid of hepatitis C in pretty much everybody. So the advent of all oral therapy that was really well tolerated really changed the game and made this feel possible.
The more that I saw all of the kind of people power and all of the amazing services and all of the amazing clinicians that were just really committed to treating hepatitis C, and the folks that were doing awesome harm reduction work, and all the really interesting research, that it just seemed like if we could sort of align all of the activities and really scale up a little bit, that we could really start to plan for hepatitis C elimination in San Francisco. What we're trying to do with End Hep CSF is bring together all of the people that are working on hepatitis C in all of the different ways in San Francisco to, again, ensure that we're really kind of doing all mutually reinforcing activities. The way that we try to do that is we have 3 work groups. We have a research and surveillance work group. This is mainly epidemiologists and researchers. We have a treatment access work group that's mostly clinicians and pharmacists, and we have a prevention testing linkage work group that's mostly folks that work in community-based settings, that do community-based testing or work at syringe access services. And then we have a coordinating committee that has representatives from each of those work groups that help make decisions about the general functioning of the initiative.
As an epidemiologist, I'm an academic. I tend to work on developing really rigorous studies to be able to produce data that is reliable. And what's really exciting for me with End Hep CSF is that I get to work with community partners, policy members, and members of our actual community we're looking to actually implement these strategies with. And so I get to be a member, a partner in this endeavor, and share the knowledge, and then help watch them actually implement the strategies using that relevant and timely evidence.
I feel like that everybody who's involved in End Hep CSF is extremely dedicated to making sure everyone gets treated without judgment and finding solutions for those who are still struggling with addiction, who might still be at risk for being reinfected. But the more that they understand that they have options and that we're dedicated to treating them, the better.
You have overdose and you have Hep C, and you just have the astonishing level of stigma. Every single person has devastating amounts of trauma and shame. And where does that come? That comes from stigma. And in the war against Hep C and winning this battle and ending it here, we have to defeat that stigma. We have to do it.
I just think it's really rough out there, particularly for homeless folks, and there's so much stigma against homeless people and drug users, and this is something so tangible and concrete that people are so empowered by, and it's like, why wouldn't we spend so much time and energy figuring out how to make this happen for folks?
Part of the success of End Hep CSF is the synergistic different agencies like working step by step together, and yet having sort of unique flavors, so we're touching different folks in different ways. So many things happened that were really good, and it came from that kind of investment of the different entities, but all sharing a very strict vision of everybody deserves treatment. The work doesn't stop, we just have to continuously lower the barrier for access and improve, people's ways of being supported for treatment success.